Morning, Tri-Cities. It's Friday at 9 o'clock. It's time for Coffee with Karl. Today's the next webisode, if you will, of our 23rd annual Regional Economic Outlook for TriDec. Today, we have our healthcare outlook. And so it's our honor to welcome Dr. Amy Person. She is, I got my notes right here. I know what her title is, but just in case I forgot, the Health Officer for Benton Franklin Health District. Good morning, Dr. Amy.
Good morning.
Thanks for joining us. We also have Reza Khalil. He is the Chief Executive for the Cadlick Health System. Good morning, Reza.
Morning, Karl. Morning, Dr. Person.
Thanks for coming in this morning. Just to let everybody know, we also invited John Solheim, who's the Chief Executive Officer for Trios Health, and Joni White-Wagner, the Chief Executive Officer for Lord's Health Network. And unfortunately, neither one of them could make it this morning, but wanted to let everyone know, this is really about healthcare in the Tri-Cities, and looking forward to a great conversation this morning. So thanks both of you for making time for us this morning. We'll kick off with our mug story, and I got a new one actually last week. It's kind of cool. It's from McKay Sposito, and they're a design firm. They focus on energy, public works, and land development. TriDec's worked with them in the past on some Hanford comprehensive land use planning that we did. And last week I was at the Regional Chamber of Commerce luncheon that was the state of the ports, and they had a table set up there. They were the sponsor, and they had these mugs, and I kind of like walked by them, and one guy who I had, since I've been here, I haven't had a chance to meet him. They go, "Hey, Coffee with Karl, you need a coffee mug." And the reason that I'm telling this story and giving a plug to Mackie Sposito is, especially as we come out and we're able to get out more and more often, almost everywhere I go, people watch Coffee with Karl. And I have to give a shout out to Tracy Zhao, who runs this. It was her idea. She puts it together. She's our producer and director. And, I just wanted to give that feedback that she does such a great job with this. And like I say, when I go out, I get feedback, and it's, my name's on it, but Tracy does everything. She does such a great job, and it's been a great way for me, especially through the 2 years since I've been here, to virtually get out and meet people and have good conversations. So wanted to give that shout out both to Mackie Sposito and then also to Tracy for doing such a good job with this series. Dr. Person, do you have a mug or mug story for us this morning, or coffee? Or whatever you're drinking?
Sort of. So I'm trying to get this. So I'm going to do kind of a call out, for all of the people here in the Tri-Cities with family in Ukraine and the people of Ukraine at the health district, because the Tri-Cities is one of the 5 areas that sees a lot of refugees over time. We've had a number of Ukrainian refugees. So just, call out for, peace for everyone who's experiencing war or armed conflict around the world. Thank you. And a shout out to Tracy too. She brings a lot of great energy. So I am always happy to say yes when I'm asked to come here.
That's great. And thanks for acknowledging the war is a horrible thing. And I think we're all hoping and praying for, a peaceful outcome, that this thing can be over and stop the suffering in those people's lives, for sure. Thank you. Okay, Reza, I know you probably got something. You've always had great mugs. Not that other people don't, but what do you got for us?
Yeah, I got something this morning that I chose for a couple of reasons. And I don't know if you can see this. It's one of these heat sensitive mugs. So it says, it's supposed to say, "At your service." And
yeah,
when the hot liquid gets to a certain point, all the letters show up. So I wanted to bring this in honor of all of our healthcare and other public service workers through all this, and just to shout out to that group. But really, that what this mug actually what it came from was my daughter got me this. We're big Will Smith and Aladdin fans in the house. So this is the genie from Aladdin on the mug, and she when I was asking her and my wife, "Hey, I need a mug for Coffee with Karl tomorrow," they insisted that I bring the genie mug. So at your service.
Awesome. It's I don't know if you call that a double entendre, but it's 2 meanings for sure in the mug. It's awesome. Well, so healthcare is obviously a huge topic still on everyone's mind, but let's just start with the check-in, and Riza, we'll go to you first. How are you doing, and how's your team doing? I know we've talked in the past about some of the huge impacts on the healthcare system, but how's it going? How are you feeling this morning?
Well, the sun's out and it's warm, so that
Yeah.
certainly helps. But I would describe current state as kind of bruised but not broken. I think we've been through a lot as a society, and certainly with our team here, we've had, and I know we'll probably talk about specific healthcare dynamics a lot in the discussion today, but we've had some obviously very particular to healthcare impacts, and we've lost quite a bit of staff through the process, and have come out of this last surge again with quite a few things we've had to work through. And then, all the economic things that we're dealing with as a society, and we can talk about some of this more, I think we're dealing with in very unique ways within healthcare, whether it's where we are with trying to get to full employment in some of these roles that we have open, or the new inflationary pressures that are going on and all that. So lots that we're thinking through. But I will say on the positive side, just relieved to see the COVID numbers having come down, so we can start focusing more on some of these other things.
I like that. I wrote it down: bruised and not broken. That's a great description. Dr. Person, how about you and your team at the health district? How are you feeling this morning? How are you doing?
I'll say I really like Riza's phrase too, because I think that can be said about public health as well, kind of bruised but not broken. We're dealing with a number of staff that have left over the last couple of years. So, but it's kind of an interesting time we're at right now. Almost, I'd say, a tipping point. The pandemic is kind of shifting. There's a lot of lessons we've learned, not just about public health, but other things through the pandemic. So trying to figure out how to put those into place because the pandemic really brought to everyone's mind the problems with the chronic underfunding of public health. We saw the legislature make some, historic changes in that. So there's some of that excitement at looking at what can we actually do. Now that we have funds, we just need to find staff. So yeah, I'm sure we'll talk a little bit more about that, but it's an interesting time.
Yeah, I know when you've been on before, we've talked about it. And a long time ago, I was a county commissioner back in Idaho. And, I think public health is an example, a great example actually, with the pandemic, that before there was probably almost no public knowledge or awareness of what is public health, what do you really do? Somebody wants to get a septic tank put in their property, right? They do perk tests and things like that. I mean, sometimes, and then obviously restaurant inspections, those types of things. But now, that lens has been almost completely reversed. And so through the last 2 years, you guys have really stepped up and, provided that critical role in public health that really, I think, was kind of the reason 100 years ago why public health was started. And so, as the numbers come down, CDC and now the governor has set some dates for mask mandates going away. Let's start off with you, Dr. Person. What are some trends or some things? I mean, have you guys even been able to almost push back from the day-to-day and say, okay, what's the role of public health in the future? And, what are some things maybe that you've learned, your team's learned? I mean, are you guys just still so in the trenches that you haven't had a chance to have that? Or can you give us an idea of what are some things that you see coming out of this that could even be positives for public health?
Sure. We are still mostly in the trenches, but we really have been looking at it. Some of the things that we've really learned from the pandemic is, one, that health or barriers to health don't affect everyone equally, even in the Tri-Cities. So how can we reach some of those populations better? And then, usually out of disaster comes innovation. So we've seen a lot of things happening that before we never would have thought about doing, or even using people to help deliver public health services that aren't necessarily public health workers, our community health workers, so people from those communities. And so how can we use that talent better? So yeah, that's really where we're looking, is how to be more innovative, and then also how to make public health really be, you know, public with involving everyone. So not just us in governmental public health at Benton Franklin Health District, but how do we continue to work more innovatively with our hospitals, our clinics, our businesses, our nonprofit organizations.
But just while we're on the subject, what are some of those barriers to health? I mean, I would imagine, you know, income level and poverty. There could be some language barriers. Are there some other ones in our community that you guys were working on, maybe even before the pandemic, that still exist when we think about barriers to health, or barriers to access to health in our community?
You've touched on, and I think the biggest ones are probably really around income, and whether that's not having a job you can take time off of to get health care, but not having enough to live in a place that's safe, access to food. The language barriers are also it. I would say it is also still, I think, some of our systems, as much as we are really working to value everybody equally, I think we still have some systems that are built in that tend to keep people of color, or sometimes even, women or differently gendered people out of those employment opportunities, because they're just not even, considered in that first blush. So those are really some, I think, the big issues we need to figure out how to move forward on.
Yeah, kind of primary and then secondary causes for some of these barriers. Yeah. Risa, how about you from your perspective, at Cadlic, what can you share with us as far as, and I know, and we'll get into, some of the staffing issues that have arisen and I know are really crippling in some cases, but how about innovation? Like what changes do you see in healthcare? And I had on our list that Tracy and I talked about, but telehealth, obviously, that I don't know if that's something that was kind of talked about before pandemic, and now maybe that's a bigger part of how do you access healthcare. But what are some things that you're seeing and your team's looking at coming out that kind of almost changing maybe some of your operational models or anything else from lessons learned in the pandemic?
Yeah, it's a great question, and I think it's a lot of things we were thinking about even prior to the pandemic happening that have just been accelerated and I think are forcing us to move a little more quickly. And relating us to what Dr. Amy and the public health folks deal with, I think we've been talking for years as healthcare systems and in hospitals about trying to find ways to get further upstream in the continuum, to keep people out of the hospital, to do all these things. And there have been marginal kind of inroads towards that, but I think through the last 2 years, seeing what happens when you can't do that and you're forced to create capacity at the farthest downstream point, whether that's talking about the ICU in particular, or just the hospital in general, for folks that either can't or won't avail themselves of some of the things that we know help to keep people from getting to that point. We're really focusing on, for the future now. We had a number of strategic projects we were looking at in 2019 with master facility planning and growth and some other things. And as we come out of the pandemic, we're very, very focused on some of the community and public health dynamics that we think we need to be more attendant to further upstream. So trying to grow primary care, we've been spending a lot of time on recruitment, trying to build our primary care strength, and knowing that in the future, there's going to be more work that can be done in the primary care office to keep people either from worsening in their conditions, looking at chronic conditions like obesity and mental health and other things that we're struggling with. And then as we look at our acute spaces, knowing that the people that do end up in the hospital are going to be sicker than what we've had in the past. So we're already seeing that play out a little bit. We track a thing in hospitals called case mix index, which is a relative measure of acuity of the patient populations you see. And over time, we've started to see now that inpatient case mix index grow over many years. And then coming out of the pandemic, we believe as other alternatives for people who are less sick, whether it's in our urgent care or express care, or as I mentioned, primary care. Hospital at home is another thing that's an innovation that's really started to pick up speed over the last couple of years. And we're working with Providence to try to understand where they're piloting that in some other parts of our system, what the successes have been, how we might be able to bring that into the arsenal of things to work with. And as you get more and more folks out of the acute hospital into those spaces, create more capacity that way. Because the big challenge for our community that keeps growing age-wise and population size-wise has been just access in a whole lot of different points. So I think trying to level load and right size the correct access points to catch people as early on in their disease progression, and be able to provide care and services to as many people as possible is a huge goal of ours. And we've all now struggled through the dark days of these surges where we couldn't take transfers in from other hospitals that needed higher level of care because we were full to what we could staff. We had, large numbers of COVID patients, as many as a third of the patients in the hospital during the peaks, COVID positive and all of that. We hope it doesn't get back to that point again, but learning the lessons of, what happens when you grind to a relative halt with ability to care for more patients. We don't want to continue to see episodes like that. So how are we building out the healthcare continuum of the future to create access points in ways that, number one, gets to people earlier on so they don't have to get into the hospital in these really acute modes of need. And when they do, making sure we have the infrastructure there to accommodate and care for them in the best ways.
Yeah. I've not heard of hospital at home. What is that? Telehealth, or what is hospital at home? It sounds interesting.
Yeah, it's a little bit more robust than telehealth. So it's where you can actually set up in a person's home a lot of the equipment and monitoring, and then have folks, appropriate care providers, come out to the home to do things. And there are certain disease processes and levels of acuity that are appropriate for that. And that patients actually really prefer their finding as this has been experimented with. And you can imagine all the reasons why, not having to sit in a hospital and be exposed to all that. Plus, from an infection prevention and other standpoint too, being in your own home and not kind of in a hospital environment can be very advantageous. But obviously not everybody qualifies for that. So as you look at your population of patients, figuring out who are the folks that could benefit from this and how can we set these services up appropriately staffed for those things now, and be able to do them in a way that makes the most sense and is still safe. I think that's the big thing, is making sure that if somebody does decline and there's something that's needed, they have rapid access to all the pieces, parts of the healthcare system they would need.
Yeah. I mean, and I'm, like I said, maybe you guys haven't gotten into it. It seems like that would potentially even take more staff to do that, or just like you're saying, you guys are looking at flexing people. I mean, is there a model where it doesn't necessarily increase the number of people that you have to hire to cover that?
Yeah, it's a different model. And so, folks can monitor a number of patients that are in the hospital at home space, depending on their acuity. And then there are folks that have to physically actually go out periodically, and there's equipment that has to be deployed. And so it's a completely different model of care in some ways than what you see in the hospital. So yeah, there are staffing implications, there are risk implications, there's a whole lot of things that have to be worked through, but it's been successfully done in a number of places. And like I said, we're trying to learn from a pilot within our own system now, but what possibilities might be for us.
We had a couple questions came in, and I think this is a good one at this point in the conversation for Dr. Person, but The question relates to the possible restructuring of the Bi-County Health Board. Will it be enlarged to include more representation? I don't know if that's a discussion. I would assume that would take like legislation possibly, or within the existing legislation, is there a way to add more members to the health board?
Actually, that is in the works as a result of the 1152, which did a number of things for public health, but one of them is a change in what constitutes a board of health. So it will expand the board of health. The requirements are that you have however many elected members you have to have at least the same number of non-elected representatives. And there's some specifics about who those people should be. So it doesn't have to include all of these groups, but you have to pick from somebody with a medical or public health background. You want a consumer of public health, ideally someone who has experienced barriers to getting health, someone familiar with environmental health things. And then some areas will actually need to have a tribal representative too. So that's all kind of being discussed and worked on. Because I do believe that some point, I think by July, the boards of health will have to be making those selections. So yes, our board of health, as well as all the other ones across the state that don't already have this kind of a mix. There are a few counties that already do have boards of health that include elected and non-elected members. So yeah, it'll be interesting. I think it'll bring a new dynamic and some new perspectives, which to me is always a valuable thing, to get different perspectives.
Yeah, it sounds like it would bring in a larger cross-section of the community, maybe for that broader discussion.
Yes.
That's great. Thank you. And what I think that kind of goes along with Reza, what we were just talking about hospital at home, but the question is, as an expansion of telehealth, has mobile healthcare for those who can't access healthcare been considered? And I would assume mobile healthcare would be like a mobile clinic or something that maybe goes, and I've seen models where for rural communities that might be more of an option, but I don't know, with the Tri-Cities, and I don't know, from Cadlic's perspective, Reza, would mobile be a part of that, or would that apply maybe more to our rural community?
It's something we'll consider, certainly, as we look at opportunities. We don't have anything in the immediate plans, but we know even within the Tri-Cities, there's some communities where we don't have a physical presence as much as we'd like to be. So whether that's expanding into those communities in a more fixed physical way, or trying to come up with ways, especially as we look at what Dr. Person was talking about with access for disadvantaged communities or people who have a lower level of access to things. How do we reach those folks? And I think anything and everything is on the table to figure out how to do that best.
Yeah. When Tracy and I were thinking about things to talk about, we had community health ambassadors on our list. And is that something that I know, through these 2 years, even working with some of our other business organizations, trying to help out. Obviously, Visit Tri-Cities was contracted with the health district for a while to actually do some advertising, some marketing and outreach on really information. But community health ambassador seems like an interesting concept. Is that something maybe that we've learned, and maybe does it relate? Like maybe we kind of learned it in the pandemic. Would it relate to removing barriers to healthcare, that for some of these communities, we need to have these trusted ambassadors? And I think in so many, that's what we're all collectively learning, right? Is like, it's not just about inviting some of these underrepresented communities to the table. It's really about how do we go to where they are in a trusted way, not just like, hey, I'm, whatever, and I'm here to help you. But is that something that's in the conversation, Dr. Person, the community health ambassadors that you guys have been looking at to break down those barriers to healthcare?
Yes, part of it, you know, overlaps with the community health workers that we've had before, and the challenge before was really trying to find a way that you could pay people to do those things. But I would absolutely agree with the pandemic. We found that trust is a huge thing, and that is part of the innovation. I won't say so much here, but you know, if you look at other communities, particularly ones where you have a high African American population, how barbershops, you know, really became the place to hold a vaccine clinic, because that's where people were comfortable going, and that's where people were comfortable getting the message that yes, this is something that you should do. You know, I'll say even in our area, you know, the Hispanic Chamber of Commerce, you know, was working with one of the clinics to do the mobile pop-up vaccine clinics, I think outside of, you know, Supermex and some other areas. And they were very, I mean, much more successful than I think any of our other clinic ideas. So we're also trying to figure out, we've been doing outreach with the agricultural community and the food processing. And so how can we take some of those relationships, some of the people we've identified in there that are trusted in those communities, and have them help guide us on how we can do better at delivering care that way. You know, and I think Cadleck is doing something similar as well, aren't they, Riza? Don't think you have some new community health workers or outreach?
We do, and we've been very fortunate to receive some funding through the Greater Columbia Accountable Communities of Health to help with the community health workers that have been doing some of the things that Dr. Amy describes. And some of our physicians and other advanced practice providers have more informally also through this, and I know some of it in partnership with the health district, gone out to particular communities that maybe have a language barrier or something. I know a couple of our Arabic speaking physicians and Spanish speaking physicians and a couple of others have tried to go and speak with different folks in community settings, talking about the vaccine in particular. But it's given us some experience with, you know, how can we formalize some of those things a little bit more in the future as we look to make a bigger impact on some of those communities.
I mean, I think this is a good conversation because I'm just struck by, like, these are things that with the pandemic related to vaccines that everybody's been going through. And then now how do you, and I'm not going to say pivot because we say pivot way too much in the pandemic, but how do we translate those lessons learned into this ongoing health issues like Riza, you brought up, mental health and obesity, which are, you know, kind of obviously huge factors in our community that affects the health of our whole community. I had a question, and I was, you know, back in October, I had some surgery. You know, I had my gallbladder removed. It went really well, but I was struck by just accessing healthcare and thinking about, you know, even during a pandemic where obviously a lot more people across all demographics and age groups and are going to access healthcare, but you know, obviously it seems like there's a higher propensity as we age, you know, that as we get older, there's more healthcare. And then even, you know, from a regional basis that people are coming in on life flight and, you know, things like that really struck me. But how do we know, you know, who's, are we doing a good job of preventative healthcare? You know, I mean, and other places I've lived, we've had, you know, community conversations around healthcare. And, you know, in some of the more remote places I've lived, as an example, we were always looking for data to show, like from the healthcare providers, they said it feels like people are sicker by the time they get here. Like, you know, and it even had you could see in the data where it affected kind of like the mortality rate and stuff. But do we see that? Like, and obviously that seems like an indicator of is preventative healthcare working? Are people accessing healthcare at the right time? And I know we talked about some of those barriers, but Riza or Dr. Amy, you have thoughts on that, or even data that show how we're doing on those factors even pre-pandemic?
Well, I will say I know that I think as a whole system, we are still skewed more towards responding to when people are sick rather than the prevention piece. I don't know if locally how good we are really having the data about showing the return on investment for prevention. We know that generally that when you invest in prevention, you're saving money, and ideally we can pull some of that from what we know from the pandemic as well. I think even if we just look at what was the most successful way to vaccinate, again, it wasn't so much the high tech or the healthcare settings necessarily. It was some of these other ones. So then to me, the big question is, how can we get the funders of health services? So we've got the legislature that is making an additional investment, but how about our insurers? Because they're good at paying for when you're sick, but not necessarily paying to keep you well.
Yeah.
With the pandemic, we've been able to do stuff because vaccines have been covered everywhere. So let's get some data from that to show that investing in other ways of doing things and prevention is of benefit.
Yeah. Reads, any thoughts on that? Yeah.
Yeah, I'll share. You asked if there's any interesting stats. So a national statistic that's a little concerning, I think, and goes back to why we think we need to get more intentional about jumping in further upstream. In 1994, the national obesity rate in the U.S. was 22%, and obesity they've defined as a body mass index greater than 30. So it's a consistent definition from year to year. In 2000, that national obesity rate had moved to 31%, and the CDC is projecting that by 2030, that will be 50%. And it varies by state. There's some interesting kind of data, and some of this is applicable to the whole country, and some of it depends on kind of where you live. For whatever reason, Colorado stands out as a state that has less of an issue with this than others, and there's probably reasons with the outdoor culture and maybe some things there, but that statistic, and if you start thinking about, I don't have numbers to define this, but what we know is going to be increasing mental health challenges because of not only what we've gone through the last couple of years, but what's been escalating, substance abuse, which is kind of rolled in there, and then you layer on top of that the aging population and all the things you talked about, Karl, with folks needing greater access. I think it really paints a picture that tells us we've got to get, as an entire society, including health systems that currently are paid more for volume than getting in front of these things. We've got to figure out how to do this and shift this. So I'm hopeful though that this last 2 years has really painted such a stark picture for folks about all those things, plus the inequities as you look across different populations that are impacted more or less by those things, that we I think have an opportunity to really dig in a little differently and maybe help that 50% number not to come to pass, and some of these other things to that we can avoid.
Well, I mean, when you look at that data, it's pretty hard not to think that, as we think about the pandemic and just the impact it's had on the healthcare industry and on public health, that we're literally not out of the woods yet. Like, maybe it's not COVID infections that we're dealing with, but these other things that mental health as an example, right, isn't getting any better with what the pandemic has, brought about in society. So, and obviously before the pandemic, we all had many conversations on, what can be done with healthcare? What are some of the things that we could do? And I just wonder, from a insurer point of view, but besides public health and the public dollars in it, that obviously insurance companies are very conservative, but they're also for-profit entities, and it seems like if you can show them a better model where they can save money and invest that into preventative. I don't know, is there anything that you're aware of, Reza or Dr. Person, on that side of it? Because obviously, I think even with like the Affordable Health Care Act and some federal things, there obviously insurers were at the table, and there was a lot of discussion about like, well, we need to make sure that this works for our systems and everything else. But do you think there's an opportunity to have that and show like, hey, maybe we can come up with a better model that's actually, as profitable, if that's, what insurers need to be able to participate, that we could get to something like that and start to focus more on prevention and start to bring some of these indicators down? Or am I just, is there too much blue sky outside and I'm bringing it inside today?
I think there's, I mean, I'll just speak from where the health systems see it. I mean, there's a lot of discussion, I think, with the insurers, and a lot of much more creative models, I think, coming out, trying to incentivize those kinds of behaviors from the insurers, but also from employers who are paying for the insurance largely for their large employee bases. So you see these large employers like Walmart and others that are selectively trying to send folks that are in their employ to centers of excellence that they know are going to have better outcomes, or try to incentivize their employees either in partnership with the insurance that they use, or sometimes if they're taking a more self-insured approach, trying to incentivize healthier behaviors and all those things. So I think from the insurance and employer standpoint, and the way they try to look at all those things, there's work being done. I think if you can combine that with things in the public arena that can be more, and if you look at what Medicare is doing too, there's a lot of innovative things that Medicare is trying to put forward with shared savings strategies, and the Medicare Advantage plans now that are administered by a lot of private insurance companies, a lot of innovative things they're trying to do. So yeah, there's a whole host of different things that are being tried, and in some cases very successfully.
Dr. Amy, I mean, on the public health side, it seems like the goal would be that, I think even with the Affordable Care Act, was that, if more people were able to actually purchase insurance on an open market, that it hopefully would take some of the burden off of public health. But any ideas on the public health side, beyond what we talked about, knocking down the barriers to healthcare and reaching out to those underrepresented communities? Anything else along these lines? I mean, along the lines of things we've learned in the pandemic and directions that way. Any other innovative models or ideas that are out there to basically raise our health level, our positive health level?
Yeah, I do think there are a number of things that are out there, and part of it to me as well is this understanding again that health isn't just about an individual, or even about the relationship between an individual and their healthcare provider if they have one. It's about the relationship of that individual to their community and to where they live. So it's that shift of other organizations really thinking about what are we doing to improve health, and how is that, and I think translating that into how is that better for everyone's bottom line, right? And that's I think the piece where in public health we're sort of working on being able to communicate that better, right? I mean, we're used to talking about data about health conditions, and we're used to that if you want to reduce obesity, that it isn't something we're going to see in a year or 3 years, or probably not even 5 or 10 years. So how do we translate that into something that makes sense to a mayor or a commissioner or a CEO of a business to say that when your employees are healthier, their productivity is better, you're paying less for their, not just their medical costs, but their lost employment, and how do you get them to see that this is an investment? Because we're good at that, right? I mean, a business doesn't have any problem saying, all right, if I get this machine and it makes me more efficient, I'll buy it even if I don't see the savings or the return on that, full return for a few years. But we have a hard time doing that when it comes to people, I think.
That's a good point. I think in the business world, so many times it comes down to that bottom line. But I think, Reza, like what you talked about, and I thought of examples in that, and maybe we'll get into this too, Reza, you kind of indicated it before, but some of the escalation in costs related to supply chain issues and inflation and things like that, which the cost in general of healthcare collectively was one of the things that led to the Affordable Care Act and everything else. But some employers have said, like, my insurance costs are so high. My cost of, providing healthcare insurance for my employers is so high that I think Schweitzer Engineering Lab that's over in Pullman, and then, they got a couple locations across the border too. They were looking at, even putting a clinic inside their operation. And I think partly it was not that they were just going to completely get away from insurance, but they knew and they saw the data and they realized that, if our employees don't have a primary healthcare doc, for example, and when they get sick, they go to the emergency room, that drives our costs up. And so I think, the clinic inside the larger employers, and obviously not everybody can do that, but I think it kind of relates back to what we talked about, is how do we come up with some hybrid models where we bring healthcare to where people live, whether it's their employment here locally. I think we talked about food processors as a great example, and maybe that's something that we learned with the vaccination clinics, but those type of things too. And I think it's like I say, access to healthcare, even for people with insurance that don't have to worry about those things as much. It's really about when you're younger, you don't think about healthcare, I think, right? You're like, oh, I'm fine, everything's great. And then you break your leg and you go to the emergency room, and there's a higher cost than if, and obviously emergencies wouldn't count. That's a bad example, but I don't know. Reza, any thoughts about that, about, models that even could work? It doesn't necessarily work for the underrepresented communities, but for employers that might be willing to take a look at something different if they can lower their insurance costs. Because to Dr. Amy's point, it does really come down to the bottom line in so many cases.
Yeah, and I'll go back to kind of maybe a more philosophical comment. I think all the things that we're trying to do are working around a setup, I guess, for healthcare that really in some ways supports kind of the wrong things, and I'll be more specific. So if you think about the EMTALA laws, and not sure if everyone knows what that is, but so the Emergency Medical Treatment and Active Labor Act of 1986, it was embedded in a budget reconciliation act around that time. And the idea of EMTALA is basically saying, hey, hospitals, you can't turn anybody away based on insurance status. If somebody comes to your door seeking care, you're obligated to see and stabilize them and provide a life-saving treatment if necessary, which is very appropriate. And same for any mother that's in active labor. And there's some what they refer to as anti-dumping laws in that EMTALA Act too, where hospitals trying to shift patients to other settings or other hospitals based on insurance status and all that. So we've guaranteed access to life-saving care at the in some cases worst situation somebody may be facing, very appropriately. There's no such guarantee for primary care or for care at the other. We have all these different complex insurance mechanisms, and so if you're uninsured, you might try to get access to Medicaid or seek out charity care in different ways, or maybe if you don't have employer-based insurance now, you can look on the exchanges and purchase a product. But we still have a fair number of folks that don't have good access to insurance and are not accessing the healthcare system until really it gets to that point where things have degraded to the stage where they need emergency care or care at a level that is going to be, from just a cost standpoint, too, incredibly more expensive than what we could have provided them as a society, as a healthcare system, so forth. So I think until some of those economic systems get reconciled, and maybe they won't at a higher level, it's trying to find all these ways at a more localized level or between the private insurances and hospitals and so forth to work through this. And as much as we say we have a private healthcare system, it really isn't. It's a one foot in both camps. 60+% of our payer mix is Medicare and Medicaid, which is government insurance, and we're very highly regulated in and around all of that. So, the things that we're trying to do working in that system that we know is set up in that way that kind of incentivizes the higher cost further down the line care is what can we do then in a way that that's economically viable, partnering with insurance companies, employers, things that we can do with public health to try to provide folks that don't have access to these more basic healthcare services further upstream. And so any effort to do that, I think that moves us forward is great. So we're open to partnering with the health district and Dr. Amy to other organizations in the community and so forth as we try to figure out, how do we get in front of some of that. And still the economics are really stacked unhelpfully, because a lot of what hospitals look at is what do we do to remain viable? And unfortunately, a lot of what the economics say is you've got to do more high-end surgical procedures. You've got to do more things that keep this acute engine going. So, it's what are we doing over time to disrupt that? And I think that the good news is this last couple of years has really forced a little more grappling with moving into that faster.
It's such a good concept. Are either of you aware of any communities that have tried to do this? And obviously, I know the last 2 years it just doesn't really affect it. But I think other communities that I've lived in, similar conversations around it. But are there any communities that have actually come together to do something with the existing laws and the existing insurers and systems that tried to do this? Are there any models we could learn out of? Because I think it's really interesting, as a community. When we're talking about potentially companies coming in or companies staying here and growing, and I know, Reza, we've talked about, bringing your industry together to say, from a community standpoint, what can we do to help with some of these staffing issues? Whether it's helping attract current talent in, anything else we can do to help on the pipeline of talent. But, is this a larger community conversation? Because I think that it's not just our community that's going through this, it's really our nation. And if there's something that we can stand up as a community initiative collectively and say, hey, this is something we're looking at, I think it just makes us that much more attractive, both to attract talent in for current jobs, with current employers. And then we're talking about companies, but are there any examples we could learn from and, maybe take a look at and then have some more conversations about?
I can share a personal example. I lived in San Antonio for many years and worked with an organization there that was the county hospital district, so publicly funded based on property taxes, but also the teaching hospital for the UT Health Science Center there. So it's a big level 1 trauma system. And they did a really innovative thing many years ago. They set up a virtual insurance that they called CareLink, and essentially said, we've got to get access to there's a huge uninsured population in South Texas. It's a big problem down there. At the time, just kind of said a way to get folks access to care earlier on would be to provide them something that approximates insurance. And so they created this product using dollars from the tax base and other things to provide people below a certain level of the federal poverty level with a virtual insurance. And they could use this insurance to access primary care and other services within this kind of closed system. So it worked pretty well in that kind of a model in a big city that's funded in that way. That's one example. A community I lived in Colorado did something unique with a local payer that was able to take Medicaid basically and raise the rates that they paid for a Medicaid product that they supported to approximate what commercial insurances were paying, and then expand access for Medicaid patients that way because more physicians and providers were willing to take so there are things like that you can do with the economics of it. I'm sure Dr. Amy's got some examples too.
Yeah, no, I was going to say those are great because I don't know that I'm as familiar. There are there have been communities that have done things, I think, around, you know, the idea of like the social bonds. So, you know, how do you get investments in things? So these, and those are some of those types of public-private kind of partnerships. So to me, a lot of that then is, yeah, really looking outside of everybody in their little box or their little silo, you know, grappling with all of the regulations that they're stuck with, and then finding something local, something, yeah, that maybe isn't bound by so many of those rules that exclude is.
I think, I mean, in so many examples that we all see so many times, you know, sometimes it just comes down to leadership, right? Because we all work within systems that have rules and regulations and everything else. And so a lot of times it's easy for all of us to just go like, it's really complex. I just got to stick to my guns. I got to do this. But, you know, bringing people together and showing them a lot of times, you know, database issues that you have, and then try to make them comfortable through, I think, relationship building and trust to say, hey, isn't there somewhere in between all these rules and regulations that we could actually do something that could actually start to help people? And it's something that we could all stand up and get involved with as a community and really be proud of. And I'd hope that we could do something like that. And I'll just throw it out that I think we'd be really interested in, you know, in bringing some of our partners out there. I was just thinking of a friend I used to work with, and he worked for either CVS or Walgreens, and they had like a mobile health clinic that they would take to cities and they would promote it. And I can't remember if it was either diabetes or high blood pressure that they were, you know, looking at like the Latinx community as an example, because there was a real high incident of one of those two diseases for the community. So, you know, they'd go out and they would promote it, and they'd bring people together to a central site, a trusted place, you know, like Dr. Amy, your example of, you know, barbershops in the African-American community or places like that. And then, you know, try to talk to people about healthcare, about, you know, monitoring your blood pressure or your diet as it affects obesity. And I don't even know if they're still doing it or if it worked, but I'm just using that as an example. As, you know, could we come up with things that, you know, both looked at the cost for employers or for individuals for healthcare and insurance, and then the underrepresented, you know, parts of our community. And, you know, as a community, take a look at it and say, hey, all of our healthcare providers at the table, public health at the table, and do something like that. And again, I know I'm looking out the window at the blue sky and I'm throwing too much blue sky out there, but I think to me, that's the thing about Tri-Cities, right? We've got a long history of coming together as a community and really addressing big issues and making something better out of the kind of the cards we were dealt, if you will. But I don't really have a question, but what do you guys think about that? Is there something that we could, you know, sit down and come out with? And I know that everybody else has 10,000 other things that they're working on, but is that something we should look at coming out of the pandemic that we should bring the community together around?
Well, I'd say absolutely. I mean, there are relationships that have been built in the pandemic, you know, between groups that have been successful. So we shouldn't lose sight of that. You know, right now we're in the midst of starting our next community health needs assessment, and, you know, to lead to the community health improvement plan. So I also think it's an opportunity to, you know, take some of that energy and channel it towards something else. So I would absolutely support looking at a way to at least start those kinds of conversations.
Yeah, I agree. I think the community health needs assessment process is kind of the perfect way to get all the folks around the table and start really talking about what are the areas that we need to focus on. And my guess, Dr. Person, is those priorities from the last round aren't going to change too much. They're just going to be a higher level of urgency, and maybe as we develop the improvement plans, cause us to think a little more differently. But I don't think the core issues don't seem to be changed much. They've just maybe worsened a little bit.
Yep. No, I'd agree. What I think may have changed is our ideas about what we potentially can do for them, because, you know, that's to me where there might be some good that comes out of the pandemic, because there were a lot of ways we, you know, delivered some preventative care during the pandemic that if you had, mentioned them, in 2018, people would have been like, yeah, we can't do that. That, you can't give, shots in a barber shop. That doesn't make any sense. You can't be parked outside the supermarket. That's not cost effective. That's not, that's not the right way to deliver healthcare. Even telehealth, I'd say,
Yeah. Yeah. Well, maybe, Dr. Person, can you tell us what the community health needs assessment is and how it works? And like you guys said, maybe it's been, I don't want to say sidelined because I'm sure you have to keep it up, but what is it and how does it work? And then are there ways that the community can get involved in it? Or is it really just a statistical look at health data and saying, here's our needs assessment?
No, it's much more than that. So
Okay.
yes, there will be plenty of opportunities. So community health needs assessment really is a way to combine both what the quantitative data might say about the health of the community, as well as the more qualitative, which is really what do people feel about what's good or not good about the health of the community. And then taking all of that, because it's always much more than you can solve in the 3-year cycle that a community health needs assessment goes through, and then prioritizing what are the top usually 3 issues that we're going to work on and what are people going to do. And it's a way to get more of the community, and that's why it's community health, right? It's not what's our hospital needs assessment or even our public health needs assessment. So there will be opportunities, many levels, for people to be involved in terms of giving their input about what do they see as the issues. There will be forums and opportunities to provide input once we have all of that data and those stories to help with the prioritizing. And then clearly we always want involvement when we're looking at what can we do. Yeah, people should stay tuned because they will be hearing about those. The process of gathering all this information goes over. We'll be doing that probably for the next 3 to 6 months. So yes, there will be many opportunities.
Right. We'll look forward to that. And again, if there's anything that we can do, let us know, because obviously healthcare is something that, as we're recruiting, trying to move into people now and talent, but then also companies that we've historically done, it's really a big issue. Healthcare measurements are something that everybody looks at, and obviously we have an outstanding community, but I think everything that we can do to help out, especially those in our community that are underrepresented and have these barriers to healthcare, anything that we can do to make the community better is better for all of us. So yeah, let us know what we can do. Dr. Person and Riza, thank you for your time today. This is, we kind of go into these as a pretty open-ended discussion, and I hope that we're able to cover the things that you guys wanted to talk about. But, thank you both for your time and your team's time in really leading us through this pandemic. I mean, this is something that nobody saw coming, and we're still here and we're still together. I know there's been a lot of challenges, but, thank you both. And Riza, you want to kick us off with maybe some final comments?
Oh, just thanks for the time this morning. It's always good to visit with you and hear from Dr. Person. And yeah, we're committed to doing everything we can to try to move this community together in the right direction, with everything from health status to still being here, obviously, for the acute care piece of this, which is not going to go away by any means. But we do look forward to getting much more involved in the future as a healthcare organization in some of the more wellness and prevention side of things.
Great. Thanks for your time this morning, and keep up the good mugs. You're kind of like a mug leader, and we're not keeping track or anything, but you have great mugs. Not that, Dr. Amy, I love it, especially your Ukrainian mug. Don't want to, it's not a comparison, but great mugs. Keep it up. Dr. Person, I just want to say, for you, you've been the point of a lot of frustration in the community, and for whatever it's worth, I just wanted to say thank you for your service, because the job that you do in the public especially is one that not everybody understands, and I think because you're an available target because you're here, a lot of people take their frustration out on you. But I just want to thank you for your service and for persevering, and to let you know that, folks in our community do support you. But any closing comments you want to give us today?
I'll just say thank you. I have really appreciated, particularly over the last couple of years, just hearing from those in the, I'll say more that, business or economic sector that, in public health, we didn't really spend time with. So I've always enjoyed hearing your perspective on things, because again, sometimes when you stare something in the face all of the time, you only see that part you're looking at. So I am looking forward to many further conversations as we move out of this sort of dark time into those blue skies that you're always talking about.
All right, well, Dr. Pertson and Riza, thanks again for your time. You guys have a great weekend, and I'm sure we'll invite you back pretty soon, and then look forward to sitting down on some of these further conversations to help our community. So thanks again.
Thanks, Karl.
Thank you.
Yep. Bye.